TOF sequence with these two different slides. Only one slide each time with an hemorrhage and very decrease a lot of white matter changes. So I am a bit skeptical. Maybe what do you decide at this stage? Thrombolysis. Okay. With side, this is not solved, and a European trial will start, or is just starting. The PI is Urs Fischer from Switzerland, to know if you have to give TPA in this case. For the moment, we still give. We have some information showing that it's probably useful, but the reperfusion. What we call TC3 is a perfect reperfusion. So the angiogram is perfectly normal after. And we have, of course, a classification I have put here. Of course, this is a radiologist usually, or the person who would do the thrombectomy, who say at the end TC2B, or if we are not in the room during the thrombectomy. So grade 0 is no reperfusion at all. This happens sometimes, especially in old patients. We cannot go to the clot and remove the clot. It's a grade 0. One is really, we were able to penetrate, but there is a minimal perfusion. Grade 2, filling is slower than normal. So it's a complete filling, but the flow is a little bit slow. It's not exactly what it should be. So it's not, and when we have a complete perfusion, it's grade 3. It has been shown that the outcome is highly dependent on having no treatment at all. So we perform the thrombectomy. We have this TC2B reperfusion. What will you decide at this stage? Yes, we do just before thrombolysis. We never do the NIH before the imaging because it's a loss of time. We just make a very quick neurological examination at baseline, and here you have the score. Usually we follow after 2 hours by a neurologist at 2 hours, 24 hours, and day 7 if the patient is still there, on when the patient is discharged. And the nurses perform also the NIH. There's a big discrepancy, of course, we do it again. So we perform this to follow the evolution. If we had worsening on the NIH of at least 4 points, in this case we need a new scan, CT or MRI. Because 4 points, at this stage we performed a diagnostic workup to classify dissection that is an ESUS. And at day 7 she left. And at 3 months, the modified ranking scale was at 1. It was already at day 7, so she recovered quite quickly. And here you have the new imaging of the patient after 24 hours. So you see a little bit better the ischemic lesion. You can see on T2 star, because T2 star is a T2 sequence, so you can see the abnormality. And your presentation at onset, you can imagine that there was probably a huge perfusion deficit in this patient. We did not, at this time, we did not perform in routine perfusion sequences, but it's likely that this patient had a perfusion defect, but we did not perform perfusion sequences. So what is an ESUS? It's a concept we always have behind the mind to sell drugs. And here, the idea behind was that in patients with ESUS, there are probably many patients with atrial fibrillation. And if this is the case, ESUS patients would benefit of anticoagulation. This was the hypothesis, but unfortunately, they enlarge the creatinine. And this is something which is quite frequent in trials conducted by the industry, which is a pity because the idea is not bad. So you have here the potential embolic sources of this ESUS. I think the big mistake for the ESUS, and I wrote an editorial for Nature Review in Neurology, to see the emboli. In these patients, we can see the emboli. So the chance that she has atrial fibrillation is very high here. But in the definition of ESUS, you just define the embolic origin because of the type of infarct and the lack of source for this infarct, which is the neurologist in charge of this. You have here the definition of ESUS, and you can see here that it's not absolutely necessary to visualize the embolus for that, which is probably the big mistake. You know that this oral anticoagulant versus one of these two oral anticoagulants in patients with ESUS, and the two failed. A little bit less for the dabigatran because the profile was a little bit different. And one of the reasons of the failure could be that many patients who meet this criteria for ESUS are not likely to benefit from anticoagulant. And probably this has thrombectomy. Of course, we need to apply quality criteria. And what are the main quality criteria to be used in these centers? What, if you perform thrombectomy and thrombolysis, what will you monitor? Who can give some idea on the level of the patient? But here I am asking, what do you monitor in your center? For instance, monitoring, I will show here, the evaluation of timing. You have to monitor your door-to-needle time. The quality criteria, I think we have probably to lower to 40 minutes now. Of course, it's not possible for all patients. Sometimes we have good reasons to lose time. If we suspect aortic dissection, for instance, it's better to do what you have to do before, and it will take time. Whereas monitoring is one of the quality criteria for the center. I am not here speaking of a patient, but if at head of the department you have to give data to your people who pay for you, you have to give this. It's not very good. So onset to needle time will also evaluate the patient, the family, and the pre-hospital part. It's important. And for patients, you have to evaluate the percentage of hemorrhagic transformation. But what is important here is not to say I have 5% or 6% or 2%, is to say expected. If you use the ECAS 3 definition, you should be around 2 or 3%, no more. So this is important. And what is important also is to know the proportion of patients who have a ranking scale 0.1 or 0.2 at 3 months, and the mortality rate, and to evaluate the patient 3 months later. But sometimes we cannot. In my area, for instance, we are on the road going to the tunnel to the UK, so we have many people coming from other countries, from Europe, and of course we will not ask a truck driver coming from Czech Republic to come back. We need to compare observed and expected outcomes, and there is a tool for that, STPI. Probably it's not valid anymore at the time of thrombectomy. What is the rate of thrombolysis per million inhabitants? This is not possible everywhere, because if you live, for instance, in Paris, you cannot evaluate, because in Paris, they treat 50 of the sea, we have the Belgian border, and in the south, the first stroke unit is very far from the area. So we can, and we have a population registry showing that 2% of patients have the stroke outside the region, abroad or somewhere. So we can evaluate. It's not possible. It's possible in Corsica, for instance, or in this kind of thrombectomy this morning, on the country, which is, we can imagine that the proportion of German patients who are not treated in Germany is probably very slow, probably 2 or 3% also, and compensated by people from outside. So this is an example of STPI to evaluate. So if you are is coming from the trials, and patients treated in trials always have better outcomes than patients treated in practice. So every time you use this STPI, your results should be a little bit worse. But look here, this is interesting. For the most, these are the worse than expected, but except for the most severe cases. And the difference here in this study is that we performed this analysis after we started with thrombectomy, and thrombectomy. Here you have the mean predicted probability to have a good outcome, which is a modified ranking scale. These variables for good outcomes, for instance, if you put these variables, you can calculate for each patient, individual patient, what is the probability to have a good outcome or the probability to die, but the variables are not the same. For catastrophic outcome, it's death or ranking 5. So if we had exactly the results expected according to the trials with the highest NIH, here the 20% with the lowest NIH, and here you have the intermediate. And usually we are a little bit worse than expected because we are not treated patients in trial. It was a long process, but at the end of the process, we started to include patients with thrombectomy. So probably we improved them. And we can do the same for catastrophic outcome, which is ranking 5 or 6, death or ranking 5. I have 3, and after you have also. Second one, this is a lady I had myself on a Saturday morning. Female, 63-year-old, 71 kilogram, and at 7:35, to be confused, which is not something usual in her. It was the first time. And he described perfectly that she had automatic movement with the left hand. Automatic movement. It was involuntary. Then the husband said the mouse was deviated. He could not say in which sense. As polycythemia, but she was not treated. She had no other ongoing therapy, no serious illness. Ranking scale was 0 before. And the GP was not expecting, not the GP, the husband was not expecting. It was my diagnosis when I saw the patient also. You have to go to the emergency department. They did not call number 15. So she arrived at 8:45. And when I saw her, she had a normal clinical examination. She could not explain what was happening. And I think was also in favor of seizure. The NIH was 0, no abnormality with the heart, normal blood pressure, a little bit high but not too much, normal biology. What would be your diagnosis in the department? I was called by the emergency physician saying, oh, I have a stroke. And he informed immediately the radiologist, and the MRI was available at this time. And the radiologist say, oh, you think it's a seizure? Will we do the MRI now or wait? And I say, oh, if it's available, if there is no patient, she will need MRI anyway, so why not now? As an abnormality on DWI in the anterior part of the insula with a decrease of ADC, of diffusion, nothing on the T2 star. The flare is normal, and she has a stop on M1. So it's probably a seizure. I think was a diagnosis, seizure revealing an ischemic stroke. Will you give TPA? Who will give TPA? Or what time? I think it was 9:46, and it started a little bit more than 2 hours before. So who will give TPA? There are 2 reasons for that. First, there is a seizure, and if you look at the old recommendations, it was not recommended to give TPA even in case of stroke if there was a seizure, because just because it was an exclusion criteria in trials, so it was a contraindication. And the other reason why I understand also that some people say, no, I don't give TPA, is that she has no symptom at all. She's completely asymptomatic. I understand also those who say, I'd give TPA, because we know that these patients, those patients who have a TIA and develop a stroke 6 or 7 years later. And for this reason, I decided to inform her, of course, to inform the husband, but she was able. Of having a neurological deficit, yeah. And for this reason, I decided to give who would not perform a thrombectomy. Actually, we did not perform a thrombectomy in this case. I have to say that this case was 2 or 3 years. It was after the trials, but 2 or 3 years before. And I think, so this is just to remind you, this is for thrombolysis, the effect of alteplase on good outcome adjusted by delay, age, and stroke severity. Just look at stroke severity. We have not the details for patients from trials included with the and you can see here that there is a benefit. The benefit exists. Of course, it's not always significant because of the statistical power, but the benefit exists also for very low NIH, not only for intermediate one or severe one. So this is, it's not enough. There is no trial performed in people with a ranking scale, with also thrombectomy, which is less proven because we have some complications, not frequent, but some complications of craniectomy. So she received TPA without thrombectomy. This was the follow-up. It was not a complete recanalization, but it was just TPA. These seizures. So it was a unique seizure. So two interests in this case. First, seizure revealing a stroke, an ischemic stroke, which is not a contraindication, and two, the question of TPA and perhaps thrombectomy in patients who have completely recovered, but have an occlusion. The deficit when they arrive. They have a mild deficit, not always severe, but usually they have a deficit. But we see this sometimes in patients with hemorrhagic stroke, and especially in those with cerebral amyloid angiopathy, old people, sometimes demented with cerebral amyloid angiopathy, who sometimes have just a seizure. But it's hemorrhagic. In this case, is to give antiepileptic drugs for the first 3 months and to perform an EEG. And if there is no abnormality, we stop after 3 months. Because if we don't stop there, they will have antiepileptic drugs for the long life. But again, there is no trial showing some people sometimes don't give antiepileptic and wait.
Sometimes an ischemic stroke can have an onset with some motor phenomenon, which does not necessarily have to be a seizure. Could you comment on that?
Yes, I have no proof that it was a seizure. What was in favor, what was described in this case, what described the family, and also the fact that the patient was absolutely unable to remember anything. I think this was in favor, but described was compatible, but very short.
As we are also dealing with movement disorders, how often have you seen TIA with shuddering attacks?
Not frequently, but not frequently as a stroke doctor, but our organization in our hospital makes it for they are on duty sometimes, so they know what is a stroke and how to treat a stroke, and they call us. I cannot remember a single patient with this, but this exists, of course. Yeah. It's a chameleon again.
My question is about this patient. Did you have difficulty to convince her to have some
mortality? Because I don't know if it's the same in Germany or in other countries. We have more problems sometimes to explain patients that we cannot give thrombolysis or cannot perform thrombectomy, especially in patients who arrived in another hospital and are referred, usually for thrombectomy. And sometimes we have very few problems with the family, but the only severe problems we had, we did not go for a trial, but I thought at one moment that we will have to go for a trial, was with a patient in whom we did not perform thrombolysis. It was 10 or 15 years ago, before the time of thrombectomy. So it was a clear contraindication for thrombolysis. And it was very, very difficult to convince the son of the patient that we did what should be done. And the person who solved this issue was a lawyer who refused. No. Oh, yes, see, I am aware for at least one patient and maybe other patients who are in close to a palliative care. Patients with very advanced cancer, for instance, they have not to
check systematically vessel for vessel after TIA.
It depends when you see the patient. If you see the patient in emergency, I think yes. I think if the patient arrives soon after the event, we should forget the term TIA. It's an ischemic event, and we forget TIA bit more time. We know that most ischemic stroke following a TIA occur within 2 or 3 days after the TIA, very soon after. After there is less risk. But in emergency, yes, it's an ischemic event. 5 kilograms. At 7 o'clock, he had sudden onset of left hemiparesia, left hemipaesthesia, and involving face, arm, and legs. And he was completely independent with the ranking scale, evaluated a posteriori, of course, but at 0. The relative skull number 15, he was admitted at 8:08 in the evening, so a little bit more than 1 hour later. And not the face anymore. The NIH was at 6, heart rate normal, normal blood pressure, normal biology. So almost normal person. And the diagnosis expected was a stroke. He had an MRI at admission, and you have here the results of the MRI. I don't show related with an ischemic event. This patient has a recent ischemic event of the left capsulocaudate area. I don't show you the picture, though there was an ischemic stroke recent. The flare was normal, but look here at this, and look at this on the TOF. On the TOF, there is no occlusion. Diagnosis, you agree that it's an ischemic stroke, recent ischemic stroke, NIH at 6, a little bit more than, it was admitted at 1 hour and 8, so maybe less than 2 hours at this stage. We took some time to perform an angio. Maybe it was a little bit of TPA, or because this patient has a clear indication for TPA. But will this aneurysm change your treatment? So who will give TPA? And who will not because of the aneurysm? Only one, no, in these patients. But we have a lot of observational data showing that we have usually no complications of TPA. The TPA will bleed at the moment of the thrombolysis, or been treated probably. And if you look at this study from the group of Markku Kaster in Helsinki, on off-label use of thrombolysis, you have many patients with aneurysms who were treated. And by us, I can imagine that it may happen that somebody was treated by TPA, and of course not published, and bled and was not published. So there is a publication bias, which is always possible. But as soon as we have patients with a stroke, who represent the general population, you will have one aneurysm. This is the proportion of aneurysms in the general population. And probably the proportion is much higher, because in this meta-analysis, which is quite old now, I think it was in 2009, I don't know if it's written, yes, did not have a TOF sequences, did not have appropriate sequences to visualize especially small aneurysms. So probably here we could see only big aneurysms. Because my question was, is it possible that ourselves, we don't treat patients because they have an aneurysm? If it's the case, we should have a proportion of aneurysms in our. It was not the case for all patients. So there was this nice study also published in Neurology a few years ago, showing that there is no reasons coming from observational studies not to give TPA if a patient is. I will repeat the question for other people. The question is it possible that the source of emboli is the aneurysm? The answer is yes, it's possible. If the stroke is in the territory of the aneurysm, of course, in this case, we have to be a little bit wise, because it's potential cause of ischemia, if it's the same territory, of course.
Une anévrisme, par exemple, au niveau de, je sais pas, l'artère pulmonaire ou est-ce que vous allez faire la thrombolyse?
I think the big is if you think, and this happens sometimes, if you think that the stroke is caused by an aortic dissection, this happens sometimes. And this is the reason why, before giving TPA, it's good clinical practice to look at the pulse at the forelimbs and to take the blood pressure at the two arms. In case it's good practice to lose a few minutes before giving TPA and to be sure. We had in our department one case where the neurologist did exactly what was in the protocol, looked at the pulse, compared the two blood pressure at the two, it's made by the nurse, and the patient was saved. We succeeded to have him treated and saved. And we were very pleased that everything was made on the checklist. This may happen. Otherwise, if it's an aneurysm that is not bleeding, no, I think it's not a contraindication. No. So, decided to treat or not, but it's another question. Any other question?
In the imaging, we have the same injury lesion, despite the fact that...
No strict correlation. For instance, what is possible is to have a DWI abnormality, which was thought in the past to be what will be the infarct in the future. And the following day, you see that the size of the lesion is cured by thrombolysis. So having DWI abnormality does not mean that it's really already an infarct. And I think this was not exactly your question. Your question, how can you explain the improvement of perfusion? Because a perfusion defect, because what is responsible for the clinical deficit is the infarct plus the perfusion defect. And probably the perfusion defect was huge, but it was a few years ago. We did not perform in routine perfusion in this time. Probably there was a huge perfusion neurological deficit of this patient with this small lesion. So there was more than that.
But, sorry, do we have to take into account the size of the aneurysm? If we, for example, we found a very big aneurysm, but no sign of rupture.
Update on stroke, not specifically on that, but I don't remember who wrote this. Published a few months ago. I think there was Tomala from Berlin in the authors, but he was not the first author on stroke. And they explain what are contraindications for thrombolysis. It's very clever. We have only 2 contraindications, complete and so on. And then we have a lot of relative contraindications, including aneurysms. And what they say inside is that we should not consider small aneurysm, and I think the definition was below 1 centimeter, as a contraindication. We should not consider very big aneurysms, because they never bleed, these big aneurysms. They are like you have to balance the benefit for the patient. For instance, if it's a patient with an aneurysm of 2 centimeters and no clinical deficit, no occlusion, I think in this case you will not treat because there is an aneurysm. So you have to balance and to evaluate the individual benefit for the patient.
I think for also entertaining and charming. And we have now 2 cases from the audience. Who is going to present them?
Je vais présenter en français. Excusez. Donc c'est un patient de 53 ans donc, qui a comme facteur de risque vasculaire donc de diabète avec l'HTA qui est sous traitement et un antécédent d'AVC de l'hémicorps droit donc avec déviation de la bouche et troubles de la parole. Et il est arrivé à l'hôpital à 8h30 et l'examen neurologique, donc on avait une hémiplégie totale droite avec une paralysie. Donc on est devant un patient de 53 ans avec un AVC du réveil, donc avec un facteur de risque vasculaire et antécédent d'AVC il y a 2 ans sans séquelles. Donc c'est un AVC du réveil, donc il faut faire donc, une IRM. Donc on a besoin d'une IRM pour voir le mismatch diffusion-flair. Donc le souci, donc brain imagerie, donc la séquence de diffusion, donc qui montre un hypersignal au niveau capsulothalamique gauche. Et au niveau de l'incus, un peu au niveau mésencéphalique, oui, pardon. Donc, EAN, oui, une partie du mésencéphale. Et sur le flair, les lésions qui sont temporales internes sont un peu visibles. Donc sur le flair, on n'a pas de coupe axiale. Et les lésions au niveau capsulothalamique ne sont pas visibles sur le flair. Donc,
So your question is, should we treat this patient? Do you have tough sequences?
moi, je pense
I
que
think the territory is
c'est
anterior
c'est
corridor
une territoire
artery.
corridor antérieur géante.
Yeah, big one.
Oui,
Maybe
big
a
one.
little bit more,
Oui.
because we have an extension a little bit to the top. Mesencephalic lesion? Right. I think two territories, and it could be cardioembolic, for instance. It's possible.
Ouais.
The same side, yeah.
Same side, same
Yeah.
moment.
How was the anatomy of the release cycle? Because sometimes you have people with a strange.
C'est pas une cérébrale postérieure fœtale qui naît de la carotide.
Okay, because
C'est-
in this case you could explain. A little bit visible on flare sequences. What was the delay between the discovery of stroke and when he came back from MRI? Because this is important also.
Yeah. Donc, pardon. Donc, on a reçu l'IRM donc à midi. Et le
I think I would give TPA in this case.
Because of negative flare.
Negative, almost negative, not completely negative, but with
Very evident.
yeah, is no
Positive.
big lesion on ML, and because of the NIH 13, because it's quite severe.
responsable de la clinique, c'est l'atteinte de la capsule interne. Et on a le mismatch sur la capsule interne. C'est pour ça qu'on a
Oui.
décidé de thromboliser.
Je pense que I think I would have given TPA also.
Avance.
Donc on a thrombalisé par la métallyse parce que l'actilyse n'est pas disponible au Maroc actuellement. Donc le scanner de contrôle donc à 24 heures, autogéné par l'ataxie. Il n'y a plus de déficit, une discrète paralysie faciale et même l'hémianopsie, il a récupéré l'hémianopsie. Donc là on a présenté le cas pour voir est-ce qu'il fallait toujours thromboliser même lorsqu'on est à 7 heures par rapport au début de symptômes. Je sais qu'on l'étude Wake Up, c'était 6 heures dans les limites. Donc il fallait agir dans les 6 heures.
A little bit later. I think the big message here is when a patient has a wake-up stroke, we should not, just because it's a wake-up, decide to stop and to say, no, we cannot give TPA. And we need MRI, of course, in this case. It's the trial, it was with MRI, but this is a big message. Don't stop because it's a wake-up and do MRI if you can.
Sur un article récent, donc ils ont essayé de voir sur les AVC de réveil avec un scanner et avec un aspect à 10. Ils ont fait le scanner puis l'IRM, donc un aspect à 10. Ils ont
It's observational, small numbers,
faux.
and the risk of publication bias. So people will not publish if it's a catastrophe, and editors will not accept saying, but you are completely outside the guidelines, and so.
Very quick. Thrombolysis alert.
Good afternoon. So I'm going to present a case about a 30-year-old woman, pregnant at 16 weeks, admitted to cardiology for infectious endocarditis, day 15 on antibiotic. Moderate dilatation of the ascending aorta, normal size and function of the left ventricle, and high gradient of the mitral valve. Presented in cardiology department June 27th at 9 p.m., sudden left hemiplegia, clinical hemiplegia, with the central facial paralysis, murism, ammonymous lateral hemianopsia, and orientation at 2. So the NIH scale at 17. So the cerebral CT performed after 40 minutes. Here is the CT. Yes, exactly.
It's what we called in the past a dense middle cerebral artery. Yeah. And here also, yeah.
There is other proposition here.
I think je pense que ça flash tellement, ça rappelle la tonalité calcique, donc c'est plus des emboles calciques que de belles sylviennes.
Look, as you see before, please here, there is 2 calcic density in the proximal cerebral artery and in the distal M2. Yes?
Classification at M1 and M2. So a CT angiography performed after 1 hour and 40 minutes.
Mr. Leys?
It was, I think you were right, it was only classification because there is no clear proximal occlusion, other not sequences but other slices. No? My impression is that we have less vessels here, so yes. Probably there is no occlusion, but quite distal, probably M2.
M2, yes,
yeah,
exactly.
Yeah.
So,
and what about early ischemic change?
And here we have early ischemic change, but these patients had contrast tendency, so. Yes. But that is clearly something here. Yeah.
Without contrast? Yes. You see.
What was the delay between the two? It was at the same moment? Or?
1 hour.
1 hour, okay.
Yes.
Usually at the same time, so,
right.
So maybe there is a change due to the occlusion also. Yeah.
So what's our...
Yes.
She has an occlusion which is probably embolic.
Calcic?
Calcic. She has, she's pregnant.
Yes.
Which term of pregnancy?
16 weeks.
16 weeks, so 4 months, so quite early. We need to know what is...
antibiotic. She had antibiotic.
Already.
Yes.
Yeah.
2 weeks after treatment.
She has no fever anymore, yeah.
So for us...
What's to do? Thrombolysis, thrombectomy, nothing? Pregnant endocarditis?
Thrombolysis, I think no. Which is also contraindication. So no thrombolysis. The question of thrombectomy, I don't know because it's calcectomy. Thrombectomy will work if it's a thrombus. We are not sure it's a thrombus. It may be part of two. We do sometimes, but it's more difficult. So the success is not a guarantee. I think I would not have treated this patient.
So
but this is clearly a case where we have to discuss
yes.
with several people, including the obstetricians also. And
this was contraindicated. For thrombectomy, the aspect was at 5, and the lesion was already evident. So the CT control after 24 hours, the lesion was evident. For the clinical evolution, after 24 hours, ultrasound was done, then the persistence of large vegetation on the posterior sigmoid of the aortic valve and suspicion of abscess at the aortic ring. So here's a quick presentation of, for calcified cerebral emboli. It's a rare cause of cerebral infarction identified by the presence of calcification. For the CT scan, is superior to MRI in identifying calcified cerebral emboli. And for the treatment, here's an article. The thrombolysis is most probably not sufficient, and priority should be given to other types of clots. Different mechanical properties of calcified clots may render them stiffer and less accessible for stent retrievers. So for stroke due to calcified emboli, there is low recognition rates and risk of peri-procedural adverse events.
Just a comment. We have Netherlands, Italy, not all Europe. And somebody asked recently to look in our database if we had pregnant patients treated by thrombolysis. And we were able to find 3 cases, one in Berlin, one in another center, and probably many have contraindications. Yeah.
Thank you.
So again, thank you very much. Others EAN Day here. And thank you very much again for our 3 speakers who came from abroad and long travel for some times. I think that the audience also was very active, pro. I think it's a very good thing for the organizer to see that it was a success. So perhaps we will call Professor Fazekas for a few words for this closing moment.
Yeah, and learned with you. I think it has been a wonderful experience. We really thank you, and I said this in an interview before, that you are so active. I mean, you are so proficient in English, in French, in Arab, but that's I cannot judge. But I think it has neurology. I think that's a privilege also, of course, to be a neurologist at these times. And I just wish you good success for your careers. I think that's also a wish for your patients, because patients are treated best if the neurologist is good. So I think we will work a lot on the possibility to further exchange ideas and information. And yeah, I just would like to ask for perhaps another group photo at the end, because Professor Teuschl was not here. So perhaps we should, please do not leave. We should just get another, so that we really are all complete.
Will be perhaps two photos, some photos here in the room, and the same photos on the stairs outside.
Whatever you want.
Okay, thank you.
Mr. Alawi? Mr. Fazekas?
From the Moroccan Society of Neurology.
Mr. Dushel?
Oui, refaites une autre photo. Monsieur Alaoui. Oui. Une autre photo devant le professeur Fazekas.